Welcome again. There's an Airway story I gotta tell you. I wouldn't believe it unless I witnessed it. So I'll tell you the story, and this was kind of like a nightmarish Airway. The Baba Yaga, the witch, or the boogeyman of Airways. Okay? I'll explain a little bit more about that title. Okay? A little later. So we have a patient who got intubated. Got a supraglottic advanced airway called an LMA in the field. Patient had been coding for 20 minutes after he was nauseous, had been drinking, and passed out. The family noticed that he wasn't breathing. Called 911 in less than 5 minutes. Paramedics found him in asystole, did CPR, gave amp of glucose, amp of dextrose, gave vasopressin, epinephrine, CPR. It was a difficult airway for them, so they wind up using their backup rescue oxygenation device called the LMA, and something that looks like an LMA, and they were able to oxygenate the patient. And in 20 minutes, the patient was ROSC, return of spontaneous circulation. So I'm trying to figure out when the patient arrives, is he a hypothermia candidate? But he's oxygenating well with the LMA. Okay? As he's oxygenating well with LMA, eventually we get blood work. We get another IV in him. They actually needed an IO in him in the field. But now that he has return to circulation, his pulses were thready and his BP was way higher than what we appreciate with the pulses. And he's on no pressors. We intubated. I know that he's already has an LMA, and respiratory thinks he's already intubated. And I was like, look at it. How many ET tubes are green? So this looks like an aura ambu device. But he's oxygenating well. But eventually, if we're going to take this patient upstairs to the ICU, they're not going to know what to do with this LMA. And for now, the LMA is not considered the definitive airway. It's not a surgical airway. It's not a definitive ET tube through the mouth. So I made a decision to extubate him from the LMA and intubate him. I let my senior on the side intubate him. He thinks he sees cords. Mind you, this patient is completely comatose. DCS of 3. No movement or pain. No eye reflexes with conguas to the eyes. No corneal reflexes. Not spontaneously breathing. So why am I going to do induction or paralyze a patient who's flaccid and not moving? He has an IV in case I needed to give medicines. So I'm trying to intubate him after we take out the LMA. And at that time, I already have my King LT in my hand. Okay? In that hand, I have a backup rescue oxygenation device. Not an air track, not a glide scope, a rescue oxygenation device. Should this LMA be needed again, or after I extubate, he deoxygenates. So I let my resident use, I think, a MAC 4 direct laryngoscopy cold steel blade. He thinks he sees something. Now, this patient is morbidly obese, small mouth, big tongue. He thinks he sees something, but he can't advance. He can't. He's not, and then he loses the airway, and he goes back in again. And this time we use a bougie. Now, you see him here using a MAC blade. He sees barely anything. The bougie, he thinks he sees something, but he says, like, there's excess tissue there. He called it redundant tissue. We put the bougie in. Right. Bougie goes in. And as we advance it, the whole thing almost disappears in the mouth. So there's no holdup. There's no tracheal ring feeling. So this is the esophagus, blind endoscopy. It's not in the right place. Okay. Then, after his 2 failed attempts, I'm starting to consider, well, this guy needs a surgical airway. I go back in there. My resident's tall. I'm not so tall, but hopefully I can get up to the height. I have an adequate height to intubate the patient. Maybe I don't. I lower the bed. I wasn't as tall as my resident, so I had to give and drop the head of the bed a little bit. Not as high as I wanted it, but because I was trying to prevent this very distended gaseous stomach from allowing aspiration to happen. Alright? So I take over. So the shorter intubator looks, and what do I see? I don't see this. I see a lot of this. Meaty, clumpy material. But of course this time, my resident already used a bougie. Already used the Mac blade. I advanced it to an air track. I'm pretty good at this. The only one that was open at the time was a small. So it was going to be a tight fit with a 7.5, but I used it. I manipulated. Eventually I went deep enough and I saw this. I saw this, and eventually I saw this little thing. Unfortunately, the reach of the air track wasn't far enough that when I tried to push it for the ET tube kept pushing here and here. So it went always under, always at the epiglottis or above it. But it did not go through there. Alright. I actually thought about using a bougie through the ET tube, almost like a cylinder technique, and it didn't work. I pull out. Luckily, we were able to re-oxygenate this patient every time with the King LT. But because he's morbidly obese, what do you think happened to the O2 sat? Every time we failed, after 20, 30 seconds, he would quickly drop to 70, to 50, even at times to 40, in less than a minute. In less than a minute. And of course, everyone would get nervous in the room, and I would throw in a King LT, the device that I had been holding earlier, and the sats would go up to 99%. Wait 2 or 3 minutes, oxygenate the patient up. I had to figure out what's the next step. So after the third attempt, after failing to place the tube with the air track, I was actually contemplating calling anesthesia, but to have them come down with the fiber optic scope. Fourth try, air track. Large. So it would probably reach this scary thing, this little thing that's hiding like a little turtle away from me, underneath all this excess of tissue. I have the bougie ready as well, just in case I have to try this MacGyver maneuver going through the ET tube and reaching. And this time, for the first time I've ever done in my career, gowned up. I gowned up my resident. He was wondering, what are you gowning up for? And I said, don't question me. And I already have my King LT, my cric kit, my portable cric kit in my pocket, ready for cutting this patient. So, some people get sweaty. I'm armed and ready, but my gloves, thankfully, are on, so that no one sees how sweaty my hands are. I go in for another attempt for the air track. The King LT that saved this patient every time with when he dropped in oxygenation was available. I didn't throw it away. He needed a large, and he was going to have it again if I needed to. If I was going to do a surgical airway, it was going to be a controlled surgical airway. I already have a plan. I was going to put this back in, this device, the King LT in, back in, and cut the neck in a more controlled manner if needed. Right. And I'm an ER doctor. I do surgical airways if needed. Okay? So, last attempt with the air track. Again, I was hoping to see what I saw before, which all is material at the base of the tongue. All as material. Then, I see a little thing like this. Something that looks smooth with structure. I manipulate some more, then I wind up seeing this. A hint, possibly a hint and it was able to guide in the ET tube. I didn't use the Easy Cap. We still had the end-tidal CO2 connector that we had for the paramedics that patient came in with from the paramedics, and the number was 45 to 50. Good waveform. I know I was successfully in, but this airway scared me. The Baba Yaga of airway for me so far in my career. AKA Lingual Tonsillar Hyperplasia. I'm about to talk about some articles about this. Okay? Thank you for letting me share this story. My Baba Yaga of airways. Thank you.